Hello, everyone. This is Chadi Alraies from RSH 2025. I'm really privileged to be with Dr. Chirag Bavishi to talk about leaflet modification for a patient with mitral valve disease. Chirag, thanks for being with us and welcome to Riyadh. Patient with mitral valve disease, valve and valve, or others, sometimes it's challenging and you have to do some techniques to modify the valve. So let's go over these techniques and what did you do with your case?
Absolutely. Thank you, Shadi, for having me. A fantastic conference and really very happy to be here. Uh, I presented a case of bioprosthetic mitral valve failure in which the patient has very small neo LVOT, which is not an uncommon scenario. And for a long time, we have been doing alcohol septal ablation, which have been the um, main technique, so as to speak, to optimize the neo LVOT. However, in some patients, that is not enough. So, over the past few years, there has been a lot of advancements of neo LVOT optimization. Lampoon has been around for some time. Jafar Khan, Dr. Greenbaum are really the pioneer in that space. But now we have modifications with a balloon-assisted leaflet modification of anterior mitral valve leaflet techniques that has really, um, you know, come into light. Particularly to speak about my case, usually you traverse the leaflet using radio frequency, and then you balloon dilate the anterior mitral valve leaflet initially with a smaller balloon, and then you go with a bigger balloon so as to create some space, and then you deploy the valve. In that way, you minimize or almost exclude any chances of LVOT obstruction. The case that I presented was we used a technique called Detroit technique, which the guys from Henry Ford recently published. In this technique, it's just the difference in how you traverse the leaflet. So usually you use electrocautery, but in this technique you use radio frequency. So you use your usual transeptal versa cross, J-tipped, and you cross the leaflet. And then the next steps are usually the same. You balloon dilate with a smaller balloon and with a bigger balloon, and then you deploy the valve. So, particularly speaking about my case, we
Yeah.
did alcohol septal ablation. The new LVOT was still small, so then we used this Detroit technique for leaflet optimization, and we got a great result.
So let's walk through the sequence. Like, did you the CT scan expected the new LVOT to be small, and you did septal ablation before the case, or you did it after as a bailout?
We did before the case.
Okay.
So the new LVOT was 133.
Okay.
We did alcohol septal ablation, and we got a good result. We were able to reduce the septum from 12 millimeters to 6 millimeters. We were able to improve the LVOT space. However, the area was still 146. So as you know, anything less than 250, there is a risk of LVOT obstruction. So we knew we need to do something else, and there are couple of options. We have Lampoon, we have Cleve technique, pioneered by Cleveland Clinic. We have Batman, which is a balloon assisted, and there are some modifications of it. And then recently the Detroit technique, which have been
Yeah.
published. So we chose to do Detroit in this specific case, and we got a good
Yeah.
result.
So can you walk through the steps of this technique?
Absolutely.
Yeah.
So you do transeptal puncture usual. You go with a medium curve edgeless sheath. You deflect the sheath towards the anterior mitral valve leaflet. Then you go with an IM catheter with the VersaCross J-tipped wire. And that's a key step in this procedure because you really want to go to the base of the leaflet near the post so that you're able to just split the leaflet from the post. So that is the most challenging part because in my particular case, the patient also had a evolute self-expanding valve. So there's a lot of shadowing, and imaging is very key in these procedures. And I don't have a biplane lab in my cath lab. So that's
That's
also,
right.
if you have biplane, it makes your life very easy. But we were able to navigate that. We were able to puncture the leaflet with radio frequency. Once the wire is across, you make sure you're not entangled in any subchordal structures. You balloon dilate with a smaller balloon. You exchange the wire with a 035 microcatheter to a safari wire, a stiffer wire. You balloon with a smaller balloon. Then you upsize it to a 14 or a 16 millimeter balloon. You balloon the septum. At that stage, patient will have an acute MR, so they may become hypotensive. Sometimes you have to use a balloon pump, but in my case, we moved very
So
fast.
the next step will be faster, just to bring the sheath in
Yes.
and deliver.
So
Yeah.
team is very important, and I'm blessed to have a great team because then you really have to go fast. My patient actually had a VT that we had to shock her out. She was a very sick lady, but fortunately, we were able to move fast and we were able to deploy a 26 millimeter valve. We also did a bioprosthetic mitral valve fracture after that with a balloon and high atmospheres. So, and there was no new LVOT obstruction, and overall it was a great result for the patient.
Well, great. And we look forward for the presentation, but we're going to be presented on this website as well. Thank you again for sharing your
Thank you.
experience and again for the challenges that you went through with your team. Watch the videos and others on YouTube channel or the website. This is Chadi Alraies coming to you from RSH 2025 in Riyadh. Thank you again, Chirag.
Thank you, Shadi. Thank you.